This talk is about normal eye movements analyzed from the perspective of bar diplopia charting. It is not specifically about bar diplopia chart interpretation, because bar diplopia chart interpretation is done using a different spatial perspective than the one we will be using during this talk. During this talk, we will go through a few key points concerning the mechanics of bar diplopia charting, briefly explain the difference between bar diplopia chart analysis and bar diplopia chart interpretation, and after we will focus on normal eye movement. This third part constitutes the bulk of this talk. A relatively easy way to understand the complexity of normal eye movement is analyzing the bar diplopia charts of patients with single extraocular muscle weakness. Bar diplopia charting is accomplished by using the Armstrong goggles, which have a red crystal on the right and a green crystal on the left, and asking the patient to look at a white bar either half a meter or a meter from the patient. The bar is first presented in the primary position. In normal circumstances, since the patient is looking through a red and a green crystal, the patient will see the white bar as having a yellow-brown color. And then, after checking the eyes in primary position, we ask the patient to look at the bar in the 8 cardinal positions of gaze: elevation, depression, dextro-elevation, levo-elevation, dextroversion, levoversion, dextro-depression, and levo-depression. A normal person looking through the Armstrong goggles will see the white bar as yellow-brown bars in all positions. On the other hand, unlike patients with normal visual alignment, patients with clinically significant eye misalignment will decouple the right and the left eye images, more or less in one or another direction, depending on the eye and muscle involved and the degree of muscle involvement. The decoupling of images produces bar arrangements with different characteristics dominated by several factors. Number 1, separation. The separation between images may be large or small. Number 2, the horizontal relation between the bars, whether the red is on the right side of the green, as in this frame, or the other way around. Number 3, vertical relation, whether the red image is higher than the green image, as in this frame, or vice versa. Number 4, inclination, whether the tilt involves the green bar or the red bar. And number 5, whether the maximal separation of the tilted bar is at the upper pole, as it is in this frame, or at the lower pole, as it is in this new frame. So far, I have illustrated the bar spatial misalignment in primary position, but this misalignment may also be present at all gaze positions. To emphasize this point, in the next few frames, we will see a patient with right superior oblique weakness and the corresponding bar diplopia chart. In this frame, you can see hyperdeviation of the right eye in primary position, maximal on levo depression, present in levoversion, and to a minor degree in depression, dextrodepression, and dextroversion, but not present in up gaze. These findings are expressed in the bar diplopia chart as yellow-brown bars in the upper gazes and different degree of bar decoupling in all other positions of gaze. The bar's separation is maximal in levo depression, corresponding to the higher degree of hyperdeviation in this direction of gaze than in all other directions of gaze where it is present. So why can we not use the content of this talk for bar diplopia chart interpretation? It is a matter of orientation. In this frame, I have presented a patient with right superior oblique under action, as the one I just showed you in the photographs, and the corresponding bar diplopia chart. This bar diplopia chart is being presented as viewed from the position used by physicians for extraocular movement examination. Notice that the relative positions of the bars matches the bar position found in the patient with right eye hyperelevation we previously introduced. This frame illustrates this position facing the patient. So the right side of the chart corresponds to the right side of the patient and to the left side of the doctor, whereas by convention for bar diplopia chart interpretation, the chart is flipped. Hence, the right side becomes the left side, and as a consequence, the intrinsic relations of the bars in each case changes. This is so because bar diplopia chart interpretation is done with a chart view from the patient's perspective. Hence, the left side of the chart corresponds to the left side of the patient and the left side of the interpreter. In other words, the representation of bar diplopia charts during this talk corresponds to the mirror image of the representation of bar diplopia charts used during bar diplopia chart interpretation. So now we are ready to jump into the meat of the subject, normal eye movements. In the right side of this frame, you can see a composite of bar diplopia chart corresponding to the underactions of the right eye extraocular muscle. The R indicates the right side of the patient, the L the left side of the patient. As you can see, this composite bar diplopia chart includes 6 individual bar diplopia charts depicting the effects of underactions of the right eye extraocular muscles: the lateral rectus, medial rectus, superior rectus, inferior rectus, superior oblique, and inferior oblique. It stands to reason that if a muscle underaction produces diplopia in a specific gaze, that the contraction of that underactive muscle is necessary to achieve monovision in that specific gaze. On the other hand, if a muscle underaction does not produce double vision in a certain gaze, it is because that muscle is not activated in that gaze. Hence, that muscle is not necessary to achieve monovision in that specific gaze. It is on this basis diplopia due to muscle underaction in a given gaze is only present if the underactive muscle participates in that gaze that we will describe eye movements. I have now introduced the right eye and will go on to name and indicate the 6 extraocular muscles: the lateral rectus, medial rectus, superior rectus, superior oblique, and inferior oblique. I will, in future frames, indicate participant muscles for each direction of gaze by changing the color of the script used for naming the muscle from white to aqua and from white to lilac for non-participant muscles. I will further show the contribution of each muscle during the different eye movements by presenting a cartoonish illustration of the electromyographic activity corresponding to the degree of activation of each of the muscles during a specific direction of gaze. In this frame, monoocular vision in primary position is being represented by a yellow-brown bar. I have done so to start analyzing the right eye muscles used in primary position based on diplopia eye charting. The eye position, in this case, the primary position, is represented in the globe by positioning the iris in the center of the globe. The position of the eye is also stated in the table's heading. So let's look at the composite bar diplopia chart, as I am indicating by the rectangles fencing the bars corresponding to the primary position. Diplopia in primary position is present with underactions of all the extraocular muscles. Based on this, we can conclude that all extraocular muscles participate in maintaining monovision during primary position, a fact that I have indicated by changing the color of the script of the muscle's name from white to aqua, and in this new frame illustrated by adding the electromyographic correlate of matched low-level motor activity in all the muscles. We must acknowledge that in patients with very minimal eye muscle weakness, diplopia may not be present in primary position and only become apparent in a particular gaze. This is so because minimally weak muscles will only produce clinically significant misalignment at the position of gaze where the weak muscle is doing most of the pulling. In these cases, when diplopia only occurs during a particular cardinal gaze position, we assume that the minimal degree of muscle under action is compensated in primary position by safety factors brought about by central mechanisms. Yet the presence of these cases do not detract from the fact that in primary position all muscles are activated to a relatively similar degree. Now we will look at right eye elevation as indicated here. As you can see in the diplopia composite chart, judging by the degree of diplopia present in cases of underaction of the superior rectus and the inferior oblique, both the right superior rectus and inferior oblique significantly contribute to right eye elevation, as illustrated here. Also, judging from the presence of a lesser degree of diplopia in patients with underaction of the right lateral rectus and right medial rectus, we can surmise that these muscles also contribute to right eye elevation, although with lesser force than the right superior rectus and the right inferior oblique, as illustrated in this frame. Based on the absence of diplopia in patients with right inferior rectus underaction and right superior oblique underaction, we can conclude that these muscles do not contribute to elevation of the right eye, as illustrated here. We will now look at right eye depression, as indicated here. You can see in the composite bar diplopia chart that neither right superior rectus nor the right inferior oblique underactions lead to double vision. Hence, these muscles are not involved in eye depression, as illustrated here. Maximal degree of diplopia occurs with right superior oblique and right inferior rectus underaction. Hence, the right superior oblique and the right inferior rectus contribute greatly and equally to right eye depression, as you can see in this frame. Underaction of the right lateral and medial recti also produce double vision, although to a lesser degree. Hence, these two muscles contribute to right eye depression, but with less intense contractions, as illustrated here. We will now look at right eye dextro elevation. You can see in the composite bar diplopia chart that neither the medial rectus, inferior rectus, nor the superior oblique underactions produce double vision during dextro elevation. Hence, these muscles do not participate in right eye dextro elevation, as illustrated here. Going back to the composite chart, you can see maximal degree of diplopia occurring with lateral rectus and superior rectus underaction. Hence, the right lateral and superior recti contribute greatly to right eye dextro elevation, as illustrated here. Right inferior oblique underaction can also produce double vision during dextro elevation, but less pronounced than lateral rectus and superior rectus underactions. Hence, the right inferior oblique contributes to monovision in dextro elevation, but less so than the two previously mentioned muscles, illustrated here. We will now look at right eye level elevation. The lateral rectus, inferior rectus, nor the superior oblique underactions produce double vision during right eye level elevation. Hence, these muscles are not involved in right eye level elevation, as illustrated here. Maximal degree of diplopia occurs with medial rectus and inferior oblique underaction. Hence, these muscles contribute greatly to right eye level elevation, as illustrated here. As you can see, superior rectus underaction can also produce double vision during level elevation, but less pronounced than medial rectus and inferior oblique underaction. Hence, the superior rectus contributes to right eye level elevation, although to a lesser degree than the medial rectus and the inferior oblique, as illustrated in this frame. We will now look at right eye dextroversion. As you can see in the composite bar diplopia chart, only the right medial rectus underaction does not lead to double vision during dextroversion. Hence, the right medial rectus is not involved in right eye dextroversion, as illustrated here. Maximal degree of diplopia occurs with right lateral rectus under action. Hence, the right lateral rectus contributes greatly to right eye movement during dextroversion, as illustrated here. Under action of the right superior rectus, inferior oblique also produce double vision, although to a lesser degree than under action of the lateral rectus. But notice that under actions of the superior and inferior recti produce more diplopia than the under action of the superior and inferior obliques. Hence, the contribution of these four muscles to dextroversion has two characteristics. The first one is that their contribution is less than the contribution of the lateral rectus. And the second one is that the superior and inferior recti muscles contribute to right eye dextroversion more than the obliques, as you can see illustrated in this frame. Notice that among elevators and depressor muscles, the fastest myogenic activity reflecting a stronger contraction is present in the superior and inferior recti. We will now look at right eye levoversion. As you can see, only the right lateral rector under action does not lead to double vision during levoversion. Hence, the right lateral rector is not involved in levoversion of the right eye, as illustrated here. Maximal degree of diplopia occurs with right medial rectus under action. Hence, the right medial rectus contributes greatly to right eye levoversion, as you can see here. Under actions of right superior and inferior oblique produce worse diplopia than the under action of the right superior and inferior recti. Hence, these muscles contribute to right eye movement during levoversion proportionally to the degree of diplopia produced by their underactions, as illustrated here. Notice the lesser contribution of the superior and inferior recti when compared with the obliques. We will now look at right eye dextrodepression. As you can see in the composite bar diplopia chart, neither the right medial rectus, superior rectus, nor inferior oblique underactions lead to double vision. Hence, none of these muscles are involved during right eye dextrodepression, as illustrated here. Maximal degree of diplopia occurs with right lateral rectus and inferior rectus underactions. Hence, the lateral rectus and the inferior rectus contribute greatly to right eye movement during dextrodepression, as illustrated here. As indicated by the arrow, the right superior oblique underaction can also produce double vision during dextrodepression, but less pronounced than right lateral rectus and inferior rectus underactions. Hence, this muscle contributes to right eye dextrodepression, although to a lesser degree than the lateral and inferior recti, as illustrated here. We will now look at right eye levodepression. As you can see in the composite diplopia chart, neither the right lateral rectus, superior rectus, nor inferior oblique underaction produce double vision. Hence, these muscles are not involved in right eye levodepression, as illustrated here. Maximal degree of diplopia occurs with right medial rectus and superior oblique underaction, as illustrated here. Right inferior rectus underaction also produces diplopia, but to a lesser degree than right medial rectus and superior oblique, and so it is reflected in their contribution to levodepression, as you can see in this illustration. So far, we have only talked about right eye muscle underaction and gone over the 6-bar diplopia chart corresponding to the underactions of each of the right eye muscles. Now we are going to talk about the consequence of left eye muscle underactions and incorporate the information gained by this exercise to the conjugated movements of both eyes. Here I have added the panel corresponding to the underactions of the left extraocular muscles. In primary position, the same muscles are involved in both eyes, that is, all the extraocular muscles. In this frame, the electromyographic activity of the extraocular muscles present during primary position is represented. Notice the low level pattern of myogenic discharge in all muscles, consistent with the weak and balanced contraction of all extraocular muscles. During elevation, in both eyes, the same muscles are activated, as indicated by the black rectangle fencing the corresponding bar arrangement, and consequently, the same muscles are not activated in both eyes as indicated by the red rectangle fencing the corresponding bar arrangement. In this frame, the electromyographic activity of the extraocular muscles present during elevation is represented. Notice that while the eyes are kept up by a strong contraction of the elevators, the midline position is maintained by the weaker but balanced contractions of the lateral and medial recti. During depression, as you can see here, in both eyes the same muscles are activated, as indicated by the black rectangle fencing corresponding bar arrangements, and consequently the same muscles are not activated, as indicated by the red rectangle facing the corresponding bar arrangements. In this frame, you can see illustrated the muscle activity present during depression. Notice that the eyes are kept down by the contraction of the depressors, and the midline position is maintained by the weaker but balanced contractions of the lateral and medial recti. During dextro elevation, as you can see here, judging by the diplopia caused by their underaction, we can conclude that the right lateral rectus and left medial rectus are activated, and so are the right and left superior recti and inferior obliques. But among the elevators, in the right eye, the superior rectus predominates, and in the left eye, the inferior oblique predominates, as indicated by the red rectangles. The right medial rectus, left lateral rectus, and in both eyes, the inferior recti and superior obliques are not involved in dextro elevation, as illustrated in this frame. The horizontal position of the eyes are maintained by the right lateral and left medial recti, and the vertical position by the contractions of the elevators, the superior rectus predominating in the right eye, and the inferior oblique predominating in the left eye. During levo elevation, the right eye, judging by the degree of diplopia, the medial rectus, superior rectus, and inferior oblique contract. Of the elevators of the right eye, the inferior oblique predominates over the superior rectus. But in the left eye, the lateral rectus, superior rectus, and inferior oblique contract, with the elevator predominance of the superior rectus, as you can see in this illustration. The horizontal position of the eyes are kept by the right medial rectus and left lateral rectus, while the vertical position is kept by a combination of elevator contractions, the inferior oblique predominating in the right eye and the superior rectus in the left eye. During dextroversion, the only not activated muscles are the right medial rectus and the left lateral rectus. The maximal contraction carried out by the right lateral rectus and the left medial rectus. Among the vertical acting muscles in the right eye, the superior and inferior recti predominate, judging by the more prominent vertical separation than is present with underactions of the obliques, whereas in the left eye, the obliques predominate, as illustrated here in this frame. Notice that the horizontal position is kept by the lateral rectus on the right and the medial rectus on the left. The vertical position is maintained by the balance contractions of the levators and depressor muscles, with the predominance of the recti on the right and of the obliques on the left. During levoversion, the only not activated muscles are the right lateral rectus and left medial rectus. In the right eye, the maximal generated force comes from the right middle rectus, less from the obliques, and even less from the superior and inferior rectus. The left eye maximal generated force comes from the left lateral rectus to a lesser degree from the left superior and inferior recti, and even less from the obliques, as you can see illustrated in this frame. Notice that the horizontal position is kept by the medial rectus on the right and the lateral rectus on the left. The vertical position is maintained by the balanced contractions of the levators and depressors muscles, with predominance of the obliques on the right and of the recti on the left. During dextrodepression, there is activation of the right lateral rectus, left medial rectus, as well as both depressors in each eye. In the right, mainly the inferior rectus, and to a less degree the superior oblique. In the left, mainly the superior oblique, less contraction of the inferior rectus, as illustrated here. Notice that on the right, the lateral rectus and the inferior rectus contract strongly, whereas the superior oblique less so, while on the left, the medial rectus and the superior oblique contract strongly, while the inferior rectus contracts less. During levodepression, as you can see, the right medial rectus and the left lateral rectus are activated, and so are the depressors, with the superior oblique predominating on the right and the inferior rectus on the left, as you can see illustrated in this frame. Notice that on the right, the medial rectus and the superior oblique contract strongly, whereas the inferior rectus less so, while on the left, the lateral rectus and the inferior rectus contract strongly, while the superior obliques less so. Thank you very much for your attention.